we're looking at the particular session I'm speaking on is about bridging therapies to CAR T, recognizing that that's a formidable challenge, given the success on the one hand of CAR T therapy, and on the other hand, especially in the relapse refractory setting with patients, the ability to bridge to the CAR becomes really challenging in a heavily pretreated setting with a person with aggressive disease. So my session is really just focusing on how do we think about that, and are there new directions we should be looking at in terms of what we do. What we know is that the use of traditional chemotherapeutic combinations, radiation therapy, IMiDs, proteasome inhibitors, those kind of combination strategies do work. They provide an ability to control disease that allows us then to move on to the lymphodepletion and actually to the CAR T. The challenge, of course, is that often the disease is quite aggressive, and in that setting there's a lot of resistance. So my focus is on really newer directions, and how do we think about minimizing the toxicities from, for example, alkylator combinations, and moving towards novel approaches which may be more effective at disease control and at the same time limiting toxicity. So we're looking at a variety of opportunities. One is, in fact, the use of CELMoDs and other types of novel agents integrated into the therapeutic paradigm in the way that one possibly can, recognizing that these obviously are not approved drugs, and so in protocol-directed conditions, that's how they would probably be best pursued. But the principle is that the use of an IMiD, the use of a proteasome inhibitor, the use of any kind of novel combination as a bridging strategy makes sense. The use of chemotherapies like DCEP in combination clearly are active. The challenge is they're quite toxic, or can be. And especially important in that regard is a non-cross-resistant strategy, so that you're more likely to be able to benefit the patient. One interesting area that's being developed, particularly in Europe, is the use of melflufen-based therapy as part of bridging. That's very interesting. It's being done in Germany, and again has been shown to be at least certainly feasible and relatively safe as a bridge, recognizing that you've collected the T cells before you use the melflufen-based treatment strategy going into CAR T. But also there are other strategies, obviously, a number of approaches, including Selinexor, which is an oral approach that can be quite effective in combination as a bridge. So my focus is to say, really, how do we do bridging? How well are we doing? We're realizing there's some real challenges. And at the same time, what newer agents make sense in that space to bridge a patient to CAR T? So just really a short introduction to that, discussion of the newer agents, and a discussion of what existing treatment strategies we have. In terms of the actual data I'll be presenting, I really focus on the real-world experiences and what we know from the prospective trials. And what I can tell you is that it's a very evolving space, and what we've learned is that actually the CAR T really matters. That's the bit that makes the difference from the point of view of a patient outcome. Where bridging therapy may be particularly important to better understand, though, is in how, by reducing the tumor burden prior to the actual CAR T, we're in then a better position to manage the toxicities. And the final piece of my presentation is really focusing on if we've got moving CAR T earlier, and we're looking at different forms of CAR T, such as allo CAR T, for example, this need for bridging will diminish. And in other words, there will not be that requirement. And that may be as important direction as any as we move CAR T earlier.